just going to move stuff about slightly so I can see. Right. So thanks very much, Jennifer, and allowing me to come along and speak to you today. What I'm going to be speaking about today is a sustainability quality improvement project that I was involved in developing within the northwest of Glasgow. So as you said, Jennifer, I'm Sandra Barber and I'm from Greater Glasgow and Clyde HSCP, and I work within the Northwest Health Improvement team. Primarily, my role is to support practices on primary care with different innovative or any pieces of work that they need some support with. And so this piece of work was actually a cluster or practice approach, and I'll be going through it today. So why are we here today? Well, effectively, the climate change, as you can see from the top two quotes here, it's the biggest single threat facing humanity is the climate change. And equally, as health professionals, we should be able to lead climate change mitigation. And that's two quotes from the Academy of Medical Royal College. But in putting into context, NHS accounts for 5.4% of the UK carbon footprint. And in relation to this piece of work, thinking about MDIs, MDIs are predominantly prescribed initially in primary care, and they contribute to 25% of the emissions. So when thinking about this piece of work, you're really thinking about what is the problem. So the MDIs, as we know, contain hydrofluorocarbons as a propellant, and that contributes to global warming. Within Scotland, in 2020, 2021, 4.5 million were dispensed, so not a small number there. The MDIs contribute to an estimated 3% of the carbon footprint of the NHS in Scotland, and the impact of MDIs is more than the fleet and waste combined, so it is a significant amount of impact. And just bearing in mind that one MDI is equivalent of driving 175 miles by car. So in bearing in mind of all that, when thinking about greener respiratory care, the NHS is a long-term plan. And what they've said is that they want to reduce the carbon impact of inhalers by 50%. So that's a mean feat in itself. However, they haven't said how they're going to go about that or how they're going to take that forward. Once they've achieved this, they've also said that they're going to reflect on the target and aim towards a net zero. So again, that's something that's great news for us, the MD who's got an interest in sustainability and climate change. However, again, there's not any direct direction or support or any audit tools or anything put in place for primary care to take that forward. And that's what I'm going to be discussing. We know that the DPIs and SMIs, the dry powders and soft mist inhalers, are a far better carbon alternative to the MDIs. And we also are it's well documented about the over-reliance of the SABAs, the reliever inhalers, and the impact that that has on carbon emissions as well. This graph just really shows what we're like in the UK. So you can see that actually we're dispensing far greater numbers than most other countries in this list of the MDIs. However, it doesn't improve anything in regards to our asthma age standardised death rate. You can see that Sweden is much lower, and they've also got a lower age standardised death rate as well. So effectively, the aim of this piece of work that I was involved with, I wanted to raise awareness of the environmental impact, reduce the use of MDIs where appropriate, and encourage a greener disposal of inhalers. For this piece of work, I wanted to develop an audit tool that was easy to integrate into primary care and practices and actually give us some data back from it. It was to be able to monitor and quantify the progress of the quality improvement that I pulled together for a practice level approach. And also wanted to gather data on the patient management, appropriate inhaler changes, and also about the reduction in greenhouse gas emissions. I'm quite passionate about climate change, and for me, the most important thing for this was actually to evidence and showcase each practice what they could do by making small changes with their patients, how we could make a huge impact in the greenhouse gas emission reduction. I also wanted to avoid increasing the practice nurse workload. I was conscious as we came out of the pandemic that they were all already up to their eyes in workload and certainly didn't have an awful lot of capacity to take on anything else. So I was very conscious of this when I was developing the audit tool, that it had to be something that was very simple, easy, and it could definitely be incorporated into their everyday asthma and COPD reviews. So I'll take you back a bit and take you on the journey of where this all started. So at the end of 2021, start of 2022, Sophie Verdi is a medical student and was working in Glasgow, a practice in the northwest of Glasgow. And Sophie Verdi done this piece of work on swapping patients from MDIs to DPIs. And then she showcased her piece of evidence. And thankfully, I was one of the people who was very grateful to hear her presentation. And to me, it was just a bit of a light bulb moment, especially because I work with about 54 practices in the Northwest, and this was one of them in the practice. And to me, the light bulb was thinking, well, this is a fantastic piece of work. She's done great piece of work here, but how can we actually replicate that, and how can we take this forward in other practices? At the same time, at the end of 2021, COP26 was on in Glasgow. So again, there was lots of media coverage about sustainability, climate change, and what people could be doing to make a difference. So to me, the two of them totally merged at the same time. And I just jumped on that opportunity and thought, right, okay, well, let's be able to promote this to other practices in the Northwest. So I held 2 primary care information sessions, and out of the 2 sessions, we get 34 clinicians coming along, predominantly practice nurses. But to me, it was a start, and I was thinking, well, at least we've sown the seed, we've given them a bit of a thought about this, shown how Sophie went about it, but really to take it forward a step further, I had already been working with Cluster A, which is one of the clusters in the Northwest, and I said to them, if I set up a QIP proposal, would you consider this, taking this forward as a piece of work? And thankfully, they were all up for it. So I pulled together a QIP proposal and also said that I would develop an audit tool that actually we could get the data direct as the nurses were doing the reviews. So I wouldn't then have to go back to them retrospectively and say, oh, and by the way, can you give me data on this? And can you give me data on that? Having done work with the past and trying to get data from practice when they're busy is really difficult. So I knew that if I wanted to evidence any of this work, I really had to give them an audit tool at the time of going forward. So thankfully, Cluster A agreed to this, and I was very thankful for that. They were also quite open for me to share any of the information in future forums, and I'll go on to speak about that. Peter Costin, as I mentioned, was the GP practice Sophie was working with, also presented at the Sustainable Healthcare presentation at the Climate Emergency event. And he also included a piece of my work at that time as well. So it did showcase to other practices what was happening within Cluster A. Thankfully, I was also asked if I would put a piece of this work into the Chief Medical Officer's report for Greater Glasgow and Clyde this year. So there is a small part within that report on this, but that gave me an opportunity to showcase the work to a lot more people than I would normally be able to be in contact with. And I would say that I've taken every opportunity to be able to speak. So thanks, Jennifer, for asking me along to speak to your session today. I was also invited to join the GGC Board Sustainability Working Group that Peter's heading up, and that's specifically looking at MDIs, specifically in regards to what we can do at a board level to take this work forward. As I mentioned, I've also presented at various groups. I'll not go through them all, but this is just a selection of them. But I would say sometimes you feel as if you're wading through treacle, but you just have to keep persevering, because if you've got a passion for something and you think it's actually going to work, if people would be willing to give it a chance, then I think it's worth trying to share it as many venues that you can. So just thinking about where the growth is, as I said, this initiated with Cluster A, 1 cluster out of 7 in the northwest of Glasgow. There's 6 practices within that cluster, and all agreed they would take this forward. Understandably, they had some reservations coming out of the pandemic, and they didn't want to give a huge workload to the practice nurses. So we all agreed that they would initially set up that the practice nurse from each practice would do 10 patients as part of the review and they'd do a test of change with this pilot audit and just see what happened from there. I would say that I'm really pleased to tell you today that actually the cluster felt that it was really worthwhile. The practice nurses liked it, and as a result, they've just kept going. So what started off as a target of 60, as today, we're now sitting at, they've done 199 initial reviews between asthma and COPD, and they've also carried out 17 follow-ups as well. A bit like that pebble in the pond is just saying, you know, how can we ripple this out and how can we replicate? So with Cluster A allowing me to showcase all their evidence and their data, actually other clusters and other practices started gaining interest. Recently, I've had 2 further clusters approach me, and they're willing to take this forward as a QIP for their practice and also include the work with the audit tool. So we would be able to get data back from each of those practices. A further 2 within another cluster have also agreed to take it forward. One of them is still to start. So in total, we've got 16 practices plus the 6 originals. Peter Costin, as I mentioned, is doing the sustainability working group, and all of the practices I've managed to recruit into this piece of work and working with the audit tool are included as Peter's early adopter practices when we're looking at this at a board level to see how we can potentially roll out stuff within a board setting for practices in Glasgow City, not just the Northwest. So thinking about GGC, I'm not a lone soldier in this, thankfully. And I would say there has been lots of other changes that have helped support this piece of work. So there's been prescribed changes in the NHS GGC formulary and the salbutamol NDI, which used to be at the top of the EMIS system when a clinician put in salbutamol, is now replaced and it's got an Easyhaler salbutamol DPI. So that's great news. The NHS formulary has also recently updated a linked script switch approach, which is a decision support tool that helps a clinician if they put in salbutamol to give them a DPI as the alternative or best use inhaler device. The primary care sustainability working group that I mentioned that Peter has also classed everybody that I'm working with as an early adopter practice. So it gives us an opportunity to showcase all the works of all the practices involved. The Respiratory MCN have also produced a prescribing guide which helps clinicians be able to look at the guide to see what inhaler device is best in regard to reducing emissions from inhaler propellant or device that they use. And also there's a primary care respiratory sustainability indicator. I will show this in the graph form at the end of the presentation, but it's worth saying that these indicators are pulled out from the EMIS system for every practice within Glasgow. However, they do have a target, which I'll show you on the graph, but it is worth saying that every practice that I went to that's now involved in this piece of work, nobody had heard about these indicators. They didn't know that they had a target set for them. So it's just again about that. There is targets getting sent, but actually practices didn't know anything about it. So it's just to try and keep them informed. This is just a couple of slides. This slide just really shows what the actual respiratory MCN guide is from the one on the left, which shows you the kind of red, amber, green for your devices. And the poster on the right is what was developed again, just to try and promote that inhalers should not be disposed of in the waste. They should go back to a pharmacy for incineration. So talking more about my QIP audit tool. As I said, I developed this and I can't say that I'd done it all by myself. I knew what I wanted, I knew the content, I knew what I wanted principally in regards for it to be easy and incorporated. However, I didn't have the IT wherewithal. So Luke Barker within the health improvement team, who's my IT guru, certainly helped me initially set this all up and has since been always there and supporting me with any tweaks that have been required. To make sure that the tool was actually fit for purpose, and also before we launched it within the cluster A, I managed to get feedback from Sandra Cahill and Catherine Tully, 2 pharmacists who also helped support the development of the tool by giving me feedback. And as expected, we did have a couple of tweaks before it went live, but all to the better because it was a better tool by the end of that. It is incorporated into the respiratory reviews. And as I said, it was also important for me to raise patient climate awareness. So actually, when you'll see from some of the data, patients did not know anything about the inhalers affecting the climate. Each practice nurses, as you know, have to go through a revalidation process every 3 years. And for me, this allows them to be able to have a bit of a report that if they decide to choose this piece of work as one of their care plans packages for the revalidation, that I can give them a report that they can input as part of their evidence. Also, in regards to this, there's a bit of a double whammy. The MDIs don't have any dose indicators, as you're aware, and as a result, most people tend to discard them when there's approximately 30% left of their medication within the MDIs. By moving on to a DPI or an easy mist inhaler where there's a dosage counter, hopefully with the future 12 months from here, they'll actually hopefully have less inhalers prescribed because they'll actually use the full dosage amount of each inhaler. So it's a bit of a double whammy, hopefully. This is one of the graphs from the report, and it just shows you each of the practices on the left-hand side, their practice codes and how many patients have done so far with their reviews. From the cluster perspective, when I was putting the reports together for this, I wanted to make sure that the data I was giving them was easy to read and was very kind of easy to follow with graphs and pie charts. Nobody really wants to sit and wade through a 4-page document heavy in text when you're already up to your eyes in primary care. One of the things that we've also struggled with to get anything back when primary care have done a piece of work from the past is a bit about the patient demographics. So I incorporated that into the audit tool so that we could easily see what are the age ranges of patients coming in, what is their ethnicity, and what is their gender. And that's equally as important as who's coming in for the reviews, but also gives us a bit more information for who's not coming in for the reviews. So going forward, if there's a big lack of a certain age or a certain gender or a certain ethnicity, then that's a bit of a kind of red flag for us to think, well, maybe we need to do a bit more work to engage with those patients. I wanted to let them see what their prescribing trends were. And as I mentioned, the previous 12 months is the number of inhalers. For me, that's the most important question for the audit tool, because that's effectively the one question that gives me the opportunity to pull out the data and actually present back to the practices what they've actually achieved in regards to climate change and sustainability, something they would not normally get. As always, the Quit Your Way team are also based within my health improvement team that I'm based in, and I wanted an opportunity for MD coming through a respiratory review to get the offer to be referred into the Quit Your Way service, and that's worked well as well. As I mentioned, there has been 17 follow-ups. However, I wanted to make sure that the audit tool, that if the patient was back as a follow-up, we didn't have to go through the exact same questions as we did previously. So we don't ask them about age, gender, ethnicity. That's tracked by their CHI number, but there's a few other questions in place of that. So thinking about the data, as I mentioned, we don't want any inhalers, especially MDIs, going into general waste, because the hydrofluorocarbons, as they break down in general waste in landfill, will leak through the canisters, which is terrible for the environment. But you can see that patients that were coming in, virtually most of them were all putting their inhalers into general waste. It is quite positive that from the follow-up reviews, although it is a small number, there's only been 17 follow-up reviews. But for me, the positive message here is that 100% of those who did come in for a follow-up are now stating that they're sending their inhalers back to pharmacy. So at least we're making small inroads. And out of the other patients, even if 50% of them are no longer disposing them into the general waste, I think that itself is another win-win. This is just really, as I mentioned, it shows you the trends of what was being prescribed and what is being prescribed. So the graph on the left is from cluster A, and you can see that the vast majority of patients that have come in for a review have been on subbutyl MDI. And the graph on the right shows that the vast majority have been switched over to a salbutamol Easyhaler. It is worth saying that not every patient will be able to go through a switch because it has to be appropriate, and it has to be appropriate treatment for the patient. At this point, I had asked the practice nurses that were involved with this if they could just give me a wee bit of feedback on what they thought of the audit tool. So it was really heartwarming to me to see that a lot of them thought it was easy, it was worthwhile, it was excellent. And thinking about where we are currently in regards to achievement. So when this started off with 6 practices, it's now evolved, and I now have 22 practices involved with this GRC work, and they're also going to use the audit tool, so we will be able to get data going forward. To date, we've collected data from 256 respiratory reviews and 17 follow-ups. From that information, we now know that the majority of patients had absolutely no awareness of the environmental impact from the MDI inhalers, and most of them, as I say, disposed of their inhalers in general waste. However, out of all the reviews, 87% of the patients reviewed were suitable and wanted to switch to a DPI. It tends to be quite a lot of times patients come in, and when you start talking about switching, they think, oh, they're putting me on a cheaper inhaler, a cheaper tablet, whatever. But it is worth saying that actually when we explained in regards to the climate impact and sustainability, that such a high amount of patients were more than happy to switch over and move on to a DPI. In regards to the follow-ups, as you've seen in the previous slide, all are disposing of their inhalers in pharmacy, which is really positive. So just thinking about what that impact means, and in regards to that question I had highlighted that's the most interest to me, this is the 4 clusters down the side that have all agreed to take on this piece of work. The Woodside and Maryhill cluster has only got 2 practices in it who are going to start. One of them's only started very recently, and one's yet to go live. Out of the Postle Park and Milton cluster as well, There's 6 practices within there. However, again, 2 have went live and 4 are still waiting to go because we still wait to go do a piece of work with them. But to date, it's just worth saying that out of all the patients that have had a review, a total in the previous 12 months, those patients were prescribed over 1,000 inhalers, 1,124. So those inhalers of MDIs equate to 196,000 miles effectively, or 22,000 kilograms of CO2. And that's what they would have used in the previous 12 months out of all the inhalers they've been prescribed. And when you think about that in context, with one inhaler is equivalent of driving 175 miles, it's quite hard to think, well, what is 196,000 miles in reality? So to put it in context, a small cluster piece of work within the northwest of Glasgow has actively made a difference by reducing the amount of emissions that is equates to 7.9 times driving around the circumference of Earth. If we do a replica, not all 100% of those patients are going to move forward and all go to DPIs, but just for the sake of this presentation, I've done a like for like. So moving forward, if all of those patients have the same amount of inhalers prescribed in the next 12 months as has been the previous 12 months, and they all move to a DPI, effectively we would still have the 1,124 inhalers, but the difference would be that that would equate to 4,400 miles, or just over 1,000 kilograms of CO2. So the impact to the environment with that shift, if we got 100% and had the same amount of inhalers, would be the equivalent of driving 0.2 times around the circumference of the Earth. Some difference. I did mention the primary care respiratory sustainability indicators, that's a bit of a mouthful, earlier, but it's just to show you that this is the data that gets pulled out from the EMIS system from each practice. Nobody knew that they had all these targets, which is the kind of orange line at the bottom. The pale blue dot was what was classed as their baseline, and that data was pulled out from the EMIS system in 2022. And the dark blue dots are the current prescription of MDIs, the numbers of current prescriptions. I spoke to the chap who deals with this data, and he gave me the most up-to-date he had last week. Unfortunately, he could only give, because there is a bit of a lag time in the figures coming through, he could only give me the figures up to April, June of this year. Bearing in mind, the clusters only started this work in mid-January, and we're now taking the figures up until June this year. But already I've taken 2 similar practices in the below graph for cluster A, and you can already see that their blue, which is our current MDIs, are now starting to track down towards their orange target. Similarly, the other practice, which was kind of similar, the dark blue and light blue dot above was sitting on top of each other. You can see that that's now starting to track down. I'm confident that if I'd managed to get data that took us up to the end of October of this year, we would have seen that these blue dots are much closer to their target than what they're sitting currently. But unfortunately, we can only get up to June 23. So just a wee bit to sum up in regards to food for thought. I would say that if you've got a bit of a passion for climate change and sustainability, and you actually have something that you think this is a bit of a light bulb moment, this is something that we could maybe start to make a bit of a change this, then go for it. As I said, I had 34 people come to my initial 2 sessions about this, and actually nobody really came back from those 2 sessions hugely enthused about it. But I persevered and I went to cluster A. In cluster A, I did agree to take this forward as a QIP. And from that, and from them being willing to share their evidence, I've now managed to get 22 practices on board. So it does show that small changes can make a big impact. And I would leave it with you just a couple of thoughts about how can you influence sustainability change today. So it might not be greener respiratory care, it might not be anything to do with inhalers, but is there anything you could do within your work that you could maybe make a difference going forward? And maybe think about it within your team. Is there stuff within your team you could do? Is there stuff at home, even the small changes can make that big difference, or with some of your partner organisations? Primary care, although I work with them and I support with them, don't have to do anything directly that I ask of them. I don't deal with any of their finance. So it was all with that whole working together, working collaboratively, being able to influence a bit of change. I feel that if I managed to make a bit of a start, and this is just the northwest of Glasgow, just think what it could be if it went nationwide. Thanks for your time. I would say that if anybody's got any questions, I'd be open to that. And I'm not sure what time there is, Jennifer, but if you wanted to, I could show you the audit tool to let you see the full report.
Brilliant. Thank you so much, Sandra. And yes, we have got plenty of time. So we've got until 4 o'clock, and we do want to make sure we've got plenty of time for questions. But while people are having a think of questions, if you'd like to show us the audit tool, that would be great.
Can you see that? So this is cluster A's. Each cluster has their own audit tool, so it doesn't get too messy. They can see what's going on within their own cluster. And I'll just go through what the report looks like, but it also let you see what the questions are that the practice nurse is completing when it's in the audit tool. As I mentioned, if you see the questions here, hopefully, you can see that it's all kind of dots, that they don't have to do a lot of text. Everything's virtually a wee dot that they click on for any other questions. But I'll just go through so you can actually see what the report looks like. So as you've seen in one of the slides, this is the practice codes down the side, and it lets us see how they're all getting on, who's working. For me, when I go in to look at the data, it also lets me see, is there maybe a practice that I think's went live, who hasn't went live? So it means I can give an opportunity to contact them and say, do you need a bit more support? Do you want me to come back out? Will we go over it again? Is there anything else you need support with? So it also lets me know, actually, they've got a lot of stuff, they're doing uni work, or they've got stuff that's happening sick. So it kind of lets me keep in contact with what's happening within each practice. This is just the patient's CAI number that shows here. Also, we can see whether our patients coming in for a face-to-face phone call or attend anywhere, but the vast majority are coming in at a face-to-face appointment. This just lets you see which contact this is. So if it's an initial, it takes you through one set of questions. If you click on follow up at this stage, it automatically takes you to a second set of questions. But for the purpose of this, we'll just whiz through the report. You can see the age of patients that are coming in vary considerably between a 14-year-old over here and an 81-year-old here, but it does let you see when the vast majority of age group that's coming in. In regards to the gender of who's coming in, you can also see that the majority are coming in are women and not men. I suppose that's not a surprise when we know quite a lot of stuff. The ethnicity for within this cluster is white. This tends to be who's attended this. But if it was a cluster who had a high demographic, it would be ME community, and it was all predominantly white, again, we would need to think about what else can we do here? What is it that we need to address to encourage people to come in for their asthma or COPD reviews? And these are just the questions to try and gauge whether patients have got any insight into the climate impact of inhalers. And as you can see, the vast majority had said no, they had no idea it had an impact. And how do they currently dispose? As I showed earlier, that was general waste. This just lets us know whether they've got asthma, COPD, bronchiectasis, or both, so we kind of know what the spill is. But you can see the majority of patients reviewed today have asthma. Now, these three questions are very similar to what's asked in an asthma review, and I just kept them very similar to the asthma review questions for the practice nurse for continuity. If a patient needed more questions for a COPD review, that's absolutely fine. They can ask that, they just don't need to put it into the audit tool, because this basis of the audit tool is just to capture prescribing, some demographics and what the climate impact is. So this is effectively, have you had your usual asthma symptoms? Has it interfered with activities? Do you feel your condition is well controlled at the moment? And again, it just lets the patient say how they feel their condition is as well. And in the last week, how many times have you used your inhaler? So it lets us see that there's actually quite a lot. Some people have used it once, but there's equally some folk have used their reliever 28 times. So again, it's a bit of an indicator to the nurse that maybe something's not too well controlled within that patient's treatment. And is this suitable in agreement? As you can see, the vast majority had said out of them all that was reviewed, 87% have said, yeah, they would. Some people who weren't happy would also said that they were trying to pick out what was the cause of them not necessarily wanting to swap. So some have said that they'd oral irritation, but equally someone had said they prefer it, but they've had a DPI in the past, or they're happy with an NDI. So there is an opportunity to put a wee bit of text in just to give us a bit more soft information. These are the graphs I showed earlier about what was being prescribed and what is being prescribed. And will they require follow-up? And again, we wanted this to show especially to the cluster, that not every patient coming in would require follow-up, again, to show that actually this piece of work didn't require an awful lot extra capacity on the practice nurses. So you can see the majority don't need follow-up, which was good. If they did need follow-up, when would they come in? And the majority are like 1 to 3 months, they'll be come back in for a review, and that could be just to get used to the device. These are the questions for the follow-up, so I'll just whiz through these. So this was really so if they did attend, that the nurse knew that they had actually done the switch. They hadn't just decided they'd go through the stockpile potentially of inhalers, of MDIs before switching. So you can see that they have switched, and also just to gauge when they last switched. And that's in case the patient came back for follow-up and was actually keen to go back to their MDI. It means that they would know, actually, having they given it a bit of a chance, have they tried this new treatment and seen it actually works for them? And equally, instead of going back to an MDI, is there an opportunity to swap them to another device, a different DPI or EMI during that review? This is about what they switched to and how are they finding it. But you can see that overall, 14% they felt better on their DPIs than their MDIs. So that's another positive as well. You can see that quite a lot of them said it was easy. They liked their new inhaler. Of course, there will be some people who have got a bit of oral irritation, tachycardia, but quite a lot also had no side effects, which was good as well. And these are the 3 questions that the asthma review that you get asked previously, just to check, do they feel their condition was well controlled, which the majority did, and their new inhalers, which was also positive. And taking into account the patient's outcomes, what was the result of that effective review of the 17? So 14 did to continue on their DPIs as originally prescribed. 1 was swapped to an alternative DPI. However, as expected, there will be some that maybe go back to an MDI, and that's fine as well. And how do you currently dispose? This was one I picked up and showed you on the previous slides about they're all disposing of them. And you can see here that some folk are ex-smokers, non-smokers, and stopped smoking, which is great, but some also declined at the moment to be referred into the Quit Your Way service, but also some had a cessation referral made as well, which was positive. I would say that if somebody requires an MDI and spacer for a reliever therapy, what I've suggested to practice is that they could put that on their acutes, and also they could then monitor how much they require of an MDI salbutamol and a spacer, but actually put their preventer on as a DPI or an EMI, and that way they could have a bit of a kind of backup should they exacerbate and need a bit of a MDI spacer to support that exacerbation, but they could effectively monitor that by putting it on their acute system. And that's it. Any questions?
Thank you, Sandra. So whilst people are having a think of questions, we've got quite a few on the Jamboard already, so I'll ask you a few of these. So did you find patients of all ages were interested in climate impact?
Well, I would say out of when I said 87%, we don't know specific what age each one was. I could pull that out from the big spreadsheet because although that report is an easy read report, there's a lot of softer information that I've got access to on a Excel spreadsheet. So you could go back and pull that out. But anecdotally, I would say if 87% of them, it would have been quite a good mix of ages that were willing to take the swap, because the vast majority agreed that they were happy to swap, specifically regarding climate change.
Thank you. What do you think was most important in getting practices on board when they already have so many asks on time and attention?
Predominantly, I think, is having a bit of a relationship. For me, that was one of the main things. I had done work with Cluster A for a number of years and supported them with work in the past. So I suppose maybe in good Scottish terms, I was a well-kent face. They knew me well. I wouldn't have went to them unless it was something I actually thought would give them a benefit and their patients a benefit. So I was quite passionate that I didn't want to just ask them to do a task for asking a task's sake. And I also wanted to make sure that if they were doing this and they were taking it forward, that I could give them that data, which have done work with practices in the Northwest pre-pandemic. And it's always been really difficult if they've taken on any sort of pilot or innovative practice to get data back from them, because it just seems to be an ask too much of them. So I knew when this piece of work came across and Sophie had showcased her evidence that I wanted to be able to showcase what they were actually making a difference, especially in regards to climate change, because they wouldn't have had that at their fingertips on any system within EMIS to actually see what that impact would be. So I was conscious that whatever I developed had to be easy to use, could be incorporated, didn't have a lot of time. The nurses, I say, the cluster all agreed to it, but the practice nurses didn't know about it. So I had to go out and meet with each of the practice nurses just to chat with them, explain the concept, what it was behind it, and show them how to sort of navigate, although the audit tool is easy, so they tended to pick that up the easiest. But again, there's always a bit of skepticism with thinking, oh, here's another thing I've been asked to do, which is why I wanted that feedback quite early doors after they've been using it for about a month, just to say, well, what do you think of it? Just be honest, let me know, because I can't make it better if you're not honest. But when they all came back saying that they thought it was really worthwhile, it gave me a bit of encouragement to say, right, okay, well, let's see if we can share this with other practices.
Fantastic. I'm not sure please correct me if I'm not asking this question right, whoever wrote it. Did the project lead to knock-on change? It sounds like the practice nurses were very enthused.
I think the practice nurses were enthused when it was explained to them. And when they actually work on the audit tool, the ones that are just coming on board now, they're in a stronger position because they can go and ask the peers of Cluster A practice nurses, what do you actually think of it, as opposed to me selling it to them. But that's quite positive as well. And because they have been really enthusiastic about it, I've just shared that enthusiasm. One of the things that they had said was how long, this is one of the things that comes up when I'm selling it or selling the concept to clusters, is how long does it take? And there is an indicator at the top of the report to see roughly how long it takes to fill in. And on average, it's about 4 minutes or 4 minutes 30. So it isn't a huge cumbersome tool that's taken 20 minutes over and above a review to fill in. And they can be doing it at the same time as a review. It just sits on a different screen. It's not within the EMIS screen, it sits separate.
And there's a couple of questions relating to the audit tool. One saying, how did practices feel about the additional time to fill in the audit tool, which you've mentioned how quick it was there, but it's still additional time. If you've only got an 8 or a 10-minute appointment, that's half of the appointment, I guess, isn't it? And also asking who filled in the audit tool. Some of the questions seem to be more for nurses and other more for patients.
The nurses fill in the audit tool. It's not filled in by the patients, but it's during the review. So whether that review is a face-to-face review or whether that's for an attend anywhere or a phone call, the nurse is the person who fills in the audit tool, and it comes up with their name on it and their practice, so you know who's filling it, even if there's 2 practice nurses in the one practice. Yeah, I think there was, to be honest, some skepticism from the practice nurses initially thinking, oh gosh, we've got enough to be doing. This is another thing to be asked. But anybody who came across a bit skeptical, I tended to follow up with an email after I'd been out and visited them and just checked in with them a couple of times to see how are you getting on, how's it working for you, and things like that. And it is a bit strange and it will be a wee bit slower initially, but that's roughly what it's down to. In regards to timing, they do it at the same time as their asthma reviews. So as they're asking the patient at their asthma reviews, how do you feel, is your asthma well controlled just now? They would be typing that into the EMIS system, but effectively all they're doing is clicking a dot on the audit tool. So it wasn't mean that they had to sit and type in the same text onto 2 fields. Anything that they were collecting within the EMIS system or Vision for their asthma or COPD review, it was all dots. So all they had to do was click virtually all the dots. And if they wanted to add any text, they could, but it was virtually like maybe 1 or 2 words. It's not heavy text.
Thank you. Someone's asked about, well, a question or more of a comment. Most patients switched to a DPI, but most did not need a follow-up. And usually a follow-up is recommended to check on inhaler technique.
Yeah, that's left to the clinician's discretion, because obviously I'm not doing the face-to-face review, I'm not doing the asthma review. So I would presume that the clinician has felt that the patient is able to go ahead and use the DPI, once it explained what they were using. I think there's also they're used quite a lot of the Asthma UK as a website, as a resource to show patients how to use inhalers. So I think that's pretty well used within practices as well. But that, again, that came down to the clinician's discretion on whether they felt that patient required follow-up or not required follow-up.
Say I don't always, if I assess a patient and they have good technique with dry powder inhaler, and often that's what the technique they're using anyway, whatever inhaler they're on, I don't necessarily follow up if I'm happy that we've had a good conversation, they've got good technique. I don't know what other people's practice is.
I mean, I suppose if you were putting somebody on initially onto an MDI and you show them how to use an MDI, you don't necessarily get them back in for a follow-up to see that they're using it. You tend to wait till they're next getting reviewed, and unless they've got any issues, they would come back sooner. But so I think it's probably similar to that.
Yeah, I agree, LJ. I think it's vital you can see the patient using an inhaler, but if you can see them use a placebo in the initial consultation and they're using it well first time, I don't always follow them up.
Thank you, Alex. So a couple more inhaler-related questions while we're on that then. Have you looked for any change in the SABA to ICS, so your short-acting beta agonist to your inhaled corticosteroid ratio on open prescribing in the practices who have engaged with this work?
No, it's the crux of that. We've tried to look at, effectively, predominantly we're looking at the device. We know that there's certainly a lot of overprescribing of SABAs, and what we've suggested to some practices is, because different practices done it as a different approach. Some practices just incorporated it when patients were due for their asthma review or COPD review. They would then incorporate this. If they were on an MDI, they would open up my audit tool and do this piece of work with them. Some other practices decided that they would target for those and look at those patients who had maybe been prescribed a larger quantity of the more than expected SABA and target it that way. But we haven't went back and looked at the actual detail. That would be something you would need to probably try and pull out a bit more from the EMIS system. And that's difficult for me to get data from the EMIS system.
This was my question, and the SABA to ICS ratio, because if you're using a lot of blue and not much controller medication, it suggests you've got poor asthma control. So this is kind of a surrogate marker for how well is the asthma controlled within your practice. And one of the reasons I asked the question is kind of as a suggestion, because it's actually very easy to get that figure from open prescribing. You just go to the right page, you put the practice name in, and you can see the trend over time of the SABA to ICS ratio. And if they're using more SABA, that suggests the control's getting worse. And if they're using less SABA, it suggests the control's getting better. And just thought it would.
Does it include Scotland, open prescribing?
Oh, I don't know. Maybe
Might
not.
only be England.
Yeah, I'm not sure, because
okay.
I've put the link in the chat to have a look.
Yeah, I think you're right.
Yeah, it does.
I'm not sure what Sandra Cahill is the pharmacist that done it, that helped me with my audit tool. I know that I just noticed a comment popping up asking if it's available in Scotland. Predominantly, it'd be worth saying that I don't actually work in the practices because I'm based within health improvement. So, and it's been a long time. I left practice nurse in 2006. So it's a long time since I've worked within the systems. But so I predominantly take guidance from speaking to the practice nurses, asking the pharmacists for their support to get it to what I think would be something of use for practices. And that's what we got to with the audit tool, something that was easy and hopefully gave them information back that was useful. But yeah, take on board, it doesn't really give us information about the ratio to SABAs to inhaled corticosteroids. So.
Thank you. And it does look like open prescribing is NHS England only. So unfortunately, it doesn't look like it would cover Scottish practices. I'm going to assume that it's a similar answer to this other question. And with the ICS LABA inhalers, were you able to differentiate between fixed dose or MART therapy?
No, we only looked for devices. We just asked how many inhalers had been prescribed, and the only thing that we got was the trends of what inhaler had been prescribed by the practice to kind of see what were the trends of prescribing of MDIs within that practice. And then also we were wanting to look at what are the trends of prescribing DPIs and EMIs going forward. Again, just to give us an idea, was a kind of like salbutamol MDI going to a salbutamol Easyhaler, which so far it seems to depict that that's kind of been the trend within this cluster. Whether different clusters, the more data I get from them, we could see actually the trends quite different in different clusters of what they've prescribed historically and what they're moving on to. And again, that'll give us a bit of a soft information to maybe look at and say, well, why is this cluster maybe prescribing more of this inhaler or that? Is it a clinician preference or whatever? So I think there's kind of soft data over and above the report that as we go forward and I gather more of it, then we could maybe start unpicking a bit more behind the scenes of it.
And then you've talked a little bit about who you collaborated with. There's a question, did you involve community pharmacy in your project? We
didn't work with community pharmacy because this was really for primary care practice-based. However, the sustainability group that I mentioned, the working group, what we're looking at just now within that group is potentially thinking about community pharmacists and disposal. From what I gather from certainly from the Greater Glasgow and Clyde board is that all pharmacies should take inhaler devices back and put them through for incineration. What we're looking at currently within this group is the potential to maybe put out purple, I don't know what it would be in England or elsewhere, but to use maybe the purple bins, which get incinerated at a higher temperature to totally eradicate the hydrofluorocarbons. So there's a piece of work kind of going on suggested in the background, but it obviously has to be floated with the community pharmacists as well to see what their thoughts are in regards to this. But if it takes off, we've been assured by Paul, who works on the board for all the all waste, that he would be then able to give us a report back to say what are the inhalers and the quantities that are coming back from the bins for incineration. So with no weights and things going forward. So it's quite exciting that, you know, there is other wee pieces of work that's going in the background. If that goes forward, we're going to work with my early adopter practices, and the bins wouldn't go across board wide. We would start off small, and we would start off maybe with the pharmacies in close proximity to the early adopter practices. Again, a kind of test a change. And then if it was working, potentially putting it forward to roll out across GGC.
Thanks. I think Artie's got a question. You're still on mute, Artie.
Yeah, sorry about that. Thanks so much for the presentation. I found it really interesting that your project focused on switching people to DPIs for an environmental reason. And so saying to patients, are you interested in a more environmentally friendly inhaler? And it's great to hear that most patients were sort of amenable to that, you know, and were interested in changing. I've sort of, in the greener practice work that we've been doing around this, taken the stance that actually we ask people how they're using their inhaler and then suggest a switch to DPI if that suits their inhalation technique better. So it becomes a clinical conversation initially and then an environmental choice after that. Did you talk about the clinical reasons why someone might want to change to a DPI, or was that conversation just environmental?
The conversation is really down to each clinician. So each practice nurse does their own practice asthma COPD reviews. And part of that, we did give them a bit of an idea of how we could broach the subject in regards to sustainability, because that hadn't really been ever broached before with patients. So it was quite, we knew it was going to be new to them. But in regards to, we knew from the off that not every patient was going to be suitable. It wasn't a blanket switch. It wasn't a blanket approach. Oh, everybody that comes in are moving right over to an EMI or DPI, because really that wouldn't be that ethical, because you do have to obviously figure out what's best for patient. And the best inhaler device for a patient is an inhaler they're going to use. So, you know, the clinicians are going with that. And that's how we said that 87% were willing to switch over. But some of that would be because the clinician maybe felt that they wouldn't have managed with a DPI, or it might have felt that it wasn't clinically appropriate for them to swap from whatever to whatever. And it has been raised that sometimes as well from secondary care, if a patient was getting reviewed at secondary care and they came with a recommendation for an inhaler that was an MDI device, that the nurses were a bit more reticent to think about swapping them to a DPI as well, because that came from effectively secondary care from the acute setting. And that's absolutely fine as well. So we knew it was never going to be 100%, but the fact we have, you know, to be honest, when we started this, I wasn't entirely sure what I would get back. But to get 87% of folk willing to at least try a DPI and who were clinically able to try a DPI, I thought that was great.
Just to follow on from that, yeah, I think the data I've seen before, when people are asked if they would switch for environmental reasons, it's a lower percentage than that. And I think RT's point is often we take a clinical approach first. So we say, can you use a DPI? Okay, great, it's clinically the right thing for you. Also, it is also better for the environment. Whereas you've gone with, this is better for the environment, will you switch? And got a very high percentage. So I think that's encouraging. It's not, that percentage is not necessarily what I would expect. So it's very encouraging that actually that question alone got such a high positive response rate.
I mean, I think it was the feedback from the nurses has been that actually patients had no clue. They had no clue about any environmental impact. And I think with the amount of media coverage and, you know, climate emergency and the amount of change that's happening with weather, I think it is starting to be more of a forethought rather than an afterthought with a lot of people. And if that's another thing that we can do to make a difference and patients are happy and it's clinically, it's going to be effective for their treatment, then I think it's a bit of a win-win.
We've just got one more question on the Jamboard, which is, have you published or are you planning to publish this work?
No, I've not published it, and I've got no plans to publish it. As I said, it started off with a wee bit of a light bulb. It's taken a bit of traction in the northwest of Glasgow. For me, it would be fantastic if practices in the south of Glasgow and the northeast of Glasgow came on board. I've had a couple of discussions with people in the south. The difficulty is there isn't necessarily somebody in their team who works the way I do with practices. So I think there's maybe a bit of a loss of rapport building, a bit of confidence with working with the health improvement teams. I mean, I can only say that anecdotally, I don't know for a fact. But yeah, I think I'm in a stronger position because I've worked with them for a long number of years. And as I say, I'm kind of well known and build rapport. And sometimes it just takes that to suggest change, because everybody thinks, oh, not another thing, I'm overloaded, there's far too much, I've just come through the pandemic. So, you know, it can be a hard sell, and it didn't take off, as you've seen in my journey slide. It wasn't like, oh yeah, everybody bought into the concept. I had to work at selling the concept. And then once it's sold and once we had the audit tool and once we got some data back, that's when it took traction, because other practices started to kind of sit up and take a bit more notice. And then, you know, the more opportunity I had to kind of do presentations and explain the work and the worth of the work, then other practices came on board. But I've got, out of all the clusters, I've still got quite a few practices who haven't went live yet, but I'm hoping by the end of this year, all the 22 are live and up and running. Any hope?
Rather than a question, which is just to say the format of your results was very impressive and easy to read and understand. And I certainly found that when looking at those graphs and the kind of numbers and words, it was nice to see it in that way rather than, like you say, lots of dense text.
Yeah.
We are just about to run out of time. So unless anyone else has got any burning questions, I think in the chat we're getting some thanks coming up. We'd just like to say thank you so much, Sandra, for sharing your presentation with us today and for allowing us to record it so we can share it with those that haven't been able to attend. And we wish you all the best of luck with rolling out your work further across Glasgow and hopefully further afield than that. So thank you. Thanks to everyone for attending.
Thanks for the opportunity. Bye.